Hello and welcome back to the Rheumatology Physio podcast. I'm Jack March, the Rheumatology Physio, and I want to introduce you to the first of 5 Axial Spondyloarthritis series podcasts. These are sponsored by Novartis, and I want to thank them very, very much for giving us the opportunity to produce this series to really get into depth about a condition that I think is poorly understood across the spectrum of medicine. So this first one is titled Physiotherapy for Axial Spondyloarthritis. We're going to go on to talk about other topics such as axial spondyloarthritis in women. We're going to talk to NAS about the experiences of patients with axial spondyloarthritis, and lots more in the pipeline for the other episodes as well. So really looking forward to recording these and creating them as a nice little package to go together, meaning that you'll have loads of information about axial spondyloarthritis. This particular episode contains members of AStretch, which if you've not heard of them, you can find them on Twitter and just search AStretch in Google, and they do lots of work for healthcare professionals for extra learning around axial spondyloarthritis as well. So on the podcast, I have got Heather Harrison, Susi Gakewood and Hannah Chambers, who between them have an absolutely tons of experience working with axial spondyloarthritis, and we really get into depth about what we can provide, what the best options are for patients, how we might provide treatments as well. We talk about virtual versus in-person appointments. We also talk about what MSK clinicians might be able to utilize their current skills to treat axial spondyloarthritis and where they might need some extra training. Really loads of information in this, and really useful. We even get down to the utility of a DEXA scan in these patients. So loads of information in here. We did have a little bit of a connection issue with Hannah's connection on the recording software, so you will need to just bear with a couple of sections where the sound is a little bit not 10 out of 10, let's say, but I've managed to clean it up pretty well in editing. Finally, before we crack on with this episode and learn loads about physiotherapy for axial spondyloarthritis, I want to direct you to a new event that I have just released. So if you go to rheumatology.physio/event, you'll find all the details there. It's going to happen in April. It's going to be a hybrid event, so there's going to be in-person tickets as well as virtual tickets, and you can go there and get those now. It's going to be absolutely unmissable, amazing speakers, really branching out for me on content creation, and hopefully I'll see you all there. But for now, let's enjoy me talking to Heather, Susi and Hannah all about physiotherapy for axial spondyloarthritis. Okay, hello everybody, welcome to the podcast, and we're going to talk all about physiotherapy and therapy interventions for axial spondyloarthritis. Today I'm delighted to be joined by Heather Harrison, Hannah Chambers and Susi Gakewood as well, and we're going to talk as much detail as we can about managing as much as we can cover that isn't related to medicines, I suppose. So really delighted to have all three on from AStretch. I'm sure we'll talk about AStretch at some point during the podcast as well. Give that a little plug. But first of all, just want to get us to introduce yourselves, if you can. If I could start with you, Heather, if that's okay. What you are up to most of the time and your sort of interests in AxSpA.
So my name's Heather Harrison. I'm a physio in the York and Scarborough Hospital Trust. I work solely in rheumatology. I have an interest in axial SPA. I actually run our physio-led inflammatory back pain clinic both at York and Scarborough. I've been a member of AStretch since it started 20 years ago. So I also run our local NAS group. So I have a sort of good interest within AxSpA.
Busy as well, I imagine, doing
yes.
Yeah. Brilliant. And if then I come to you, Susi.
Hello, everyone. My name is Susi Gakewood. I'm a rheumatology physiotherapist working in MSK outpatients at Northern Lincolnshire and Gold NHS Trust, which is in the northeast coast of England. I am very proud to call myself as an AStretch member, been working with it for 2001, and I run the local Grimsby Town NAS group. Recently, I've been working on Tai Chi for Axial SPA, and I've done the part 1 in January, and I'm looking forward to do one in January 2022.
Brilliant. And then last but not least to Hannah.
Hi, I'm Hannah Chambers. Thank you, Jack, for inviting us on behalf of AStretch as well, but to advanced practitioner. And that's for East Kent Hospital's NHS Trust. I work part-time. I also work in MSK in primary care for a private practice as well as in NHS patients. So I do the combination of the two. But within my role in rheumatology, I see all sorts in rheumatology. It's not specifically AxSpA. I see plenty of AxSpA, but I do a bit of everything really. With regards to AStretch, I've been part of the committee probably only it's been the past year, so more recently.
A little bit newer compared to Heather and Susi then, who have certainly led the way there. Lovely. Okay, so as I mentioned, I want to really get into all of the topics that we can get into with regards to axial spondyloarthritis. And I'm going to keep saying physiotherapy, but really we mean therapies. We might have some osteopaths and chiropractors and whoever else listening. So I want to give them a bit of advice too. So I want to start off with you, Susi, if that's okay. We'll start really simple with what is it that axial spondyloarthritis patients need from physiotherapy in general?
As a physiotherapist, I would always give consideration to the patient's needs. So it's going to be physio, not led. It's going to be a patient-led physio program. And the goals will be based on their expectations. So if you think about patients' expectations, you're looking at 3 things. They normally would like to get relief of their symptoms. So if you look at that section, the symptoms could be pain, fatigue, stiffness, which are the 3 main components with all our patient group. I'm sure you all agree on that. So the other things which you can also interfere is interference with work, struggling with activities of daily living, with their mobility, general flexibility reduction, and also you're thinking about different lifestyles they lead, and that needs big consideration. And the next thing I would say to you is the severity of the disease. What do they face? Do they face the disease progressions in different levels? Because nobody comes equal. Everybody is different from everybody. So are they facing the disease severity, particularly in a moderate level, a mild level, or severe level, which stage they are in? And according to that, their needs change. And the third one is the treatment. What treatment they are undergoing now? Is that what they need? Or you're going to have a change? Is it according to the disease progression? Or is it according to the symptoms? So there you go, you got a bottle of 3 things together mixed. With the pain relief, physios will have to provide the needs to the patients, giving them the required modalities. Some modalities are liked by the patients. They like the heat packs. So we start with that. And some patients are very, very highly intellectual. They go into the newly manufactured pressure guns I've heard of. So you can go from the newly invented ones to the routine traditional hot packs. You name it, you can pick it up. But you got to really go along with patients' likes. Is that what they want? They feel better with it. Is that coping? They are coping with that pain levels. How is the pain levels? Are they going to monitor with the VAS score? If they have 5 out of 10, and if they have a heat pack, does it go down at least by 2? These are the things you got to start thinking and reassuring them each stage and asking them, is that what you really need? Is that what it's like by your body? Is it the pain control? So likewise, you would do with the fatigue level as well, looking at answering whether the energy levels, how are the energy levels? They are particularly coping with pacing. Do they know at all about the 4 Ps in their life? Do they know about how to plan? Do they know how to prioritize? Do they know how to pace activities, balance them? And do they know how to position when they're resting to avoid postural problems? Then the stiffness, obviously, everybody's getting stiff, especially early morning stiffness. And again, things like they can't tie the shoelaces first thing in the morning. So you can give them some pain-graded exercises, giving them a relaxed, gravity-free treatment position, which they can actually self-employ at those stages and then probably progress with the exercises or regress regarding the pain levels. So I would give them that ownership. So this is what it is. Try them, come back and tell me. Trial and error wins the race, because it might work with one person, may not be with other. So explaining them and reassuring that you're not going to be the same, that wins the race. So patients will start liking you, and then slowly they start opening them worries and then say, look, I am a sedentary lifestyle holder. I don't like to exercise. So there you go. You open a bottle of worms and you can say, okay, what are you doing actually? Why is that you don't like the exercise? Then actually explaining to them, it's okay to discuss. Some people don't like to discuss. So who will come and tell that I am actually a couch potato after I finish work? So it is something for them to talk about that. So getting the tolerance to the drugs, getting the tolerance to the exercises, slowly progressing them and regressing them. Then you become a patient counselor, you become a listener, good listener, you become a big communicator, you become a mentor, and then the physio wins the case. The third one is you're providing the treatment, the right protein. And treatment can be a big different thing. I'm sure Hannah and Heather will talk a lot about the treatment as well. You can give them 2 boxes in their hands. This is what I would do. One box is a small box, very small, but it's got lots of things. I call that as a flare-up box. So you can have the resting positions, pain modalities, the general pain-graded relaxed exercises, which they can do, which can condition the muscles, which can relax the muscles, and then get ready to exercise during the flare-up periods. And that shouldn't really hurt them. So they will get more reassured to do more exercises. And you give the key to them. That is the ownership key. Every person should be given the ownership key from my side. So the large box will tell about the general exercises. You name so many exercises are there in this world. So you can, but you can actually progress those exercises to a specific as well as the general exercises to improve the cardiovascular fitness and aerobic capacities. So you can tell them this is where it is. You can progress, you can come back, but you need to open the key. We can reassure you, we can encourage you. The reassurance and the informed education will actually tell the person to go and use the key often. And once the flare-ups are addressed, you can actually get them to go towards the fitness level. And if the key gets rusted, it's either the disease progression or is it you not guiding the patient or the patient problem. You get all the limitations. And there you go. That is the way you handle.
Lovely. I really like that analogy, the key with boxes and keys. I'm stealing that. I've written that down, just stealing that forever. I just wanted to ask you while we're on this subject, and we were saying about how you've been part of AStretch since 2001. I was just wondering if you've seen any change. We've seen a lot of medical management change over that period of time. I wonder if you've seen your role in physiotherapy change, particularly with patients obviously improving quite quickly and getting back to much more function.
Yes. Are you asking me, Jack?
Mm-hmm.
Yes. I think the drugs have taken a massive change since I started. We never had biologics. Anti-TNF is a new tonic and it's a kick. So when I came into this country and I saw ankylosing spondylitis patients, some of them are wheelchair bound, some of them had a very stoopy posture. Now I hardly see that because the biologics have taken over and reducing the inflammation. The next one is when the delayed diagnosis, it was 12.5 years, if you agree with me, Heather, there. So when we started, it was 12 years plus, and now it's come to 8.5, and we're working to get to 1 year, aren't we? But we are trying our best. So these 2 things have taken on board. Exercises-wise, I think we did a lot of different IT technologies have come. You name it, the apps have come. The DVDs, CDs, now it's gone to apps. So I'm still not aware of all the IT. I'm quite thin in that ground, but children teach me how to do things. So now we can do a WhatsApp video call and do the exercises. If the Zoom is not working, I switch on to WhatsApp call. How many of us did any exercises like that virtually? Over the COVID, we did the Zoom, and we're still doing the Zoom for 18 months. So there you say. So these 3 different types, the drugs, the different ways of exercising. You don't have to really literally see. Virtually you can do it. And you can do face-to-face, you can do groups. You can do remotely control patients, which is a big high standard.
That really nicely rolls us into what I was going to ask Heather, actually, which is the basic question being, how might we best deliver physio? And I was wondering about, obviously, with COVID, the last 18 months, 2 years, we've seen its explosion of online and virtual appointments, as Susi's just mentioned. Have we seen patients really taking to virtual appointments, even though they can come back to face-to-face a little bit? Is it a lot of people wanting one-to-one or group type exercises? You mentioned about NAS groups. I know they've been amazingly successful over time. What's, without us saying, it's slipping to is the patient's preference. What do you feel is the best way of approaching the management styles here, Heather?
I guess, obviously, COVID has really changed everything in how we approach physio in general, axial spa or rheumatoid or whatever we do. Certainly, I do the inflammatory back pain clinic that I run, literally would measure patients usually every year. We'd do their BASME, we'd do all their BAS indices, and then I'd see them potentially in physio. I think the patients in the clinic that I'm going to class this more as a rheumatology clinic like to be seen face-to-face. They like that measurements to be done. And I know they are working on virtual measurements. So I know there are a couple of different universities looking at how we can do that at home. I think that would be brilliant for patients to be able to do their measurements in between at home. It's difficult, isn't it? Personally, I quite like the idea of seeing somebody once, doing their measurements, having a look at them, looking at their balance, looking at every aspect. And from then, really whatever the patient likes, virtual, telephone. We do a sort of Zoom call with patients. A little bit difficult to even see movement through Zoom, but you get the contact with patients, being able to see them face to face. So I think there's a bit of everything. I think certainly we won't go back to the everything face to face that we used to do. And I don't think we need to, because certainly a telephone call, if you know somebody's managing exercises, you just want to have a catch up, see how they're doing with other aspects that you can do over the phone. I think that's ideal, and stops patients having to travel. Certainly where I live, we're quite rural. Patients might take an hour to get to an appointment, which really, well, if they've got AS, you don't want them sat in a car for ages waiting to come. So I think there's loads of possibilities. I think also group sessions are brilliant, certainly for giving education for patients. If you've got patients in a room, there's so much knowledge about how to manage a condition, not just from the therapists that are doing it, but from the people who live with it every day. And I think getting people in a group, whether it's over Zoom or whether it's face-to-face, has that sort of pros of doing it. So I think there's just different ways of looking at it. I would never have thought of doing a group over a Zoom before this. Like I say, technology is not my forte. Yeah, we've been doing our NAS group by Zoom since the beginning of April last year. And the patients love it, and they can manage to exercise in their own home. They've got we know what's going on. They've still got that community, which is really important, especially when we were sort of properly locked down to begin with. They've got that connection. So I think there's lots of different things that we can use, not just with NHS, but obviously with charity groups like NAS, to keep people connected and keep them not just exercising, but all that sort of mental health as well, which is really important. When you've got a chronic condition, you need that support of peers. And I think sometimes I did a little survey a couple of weeks ago with our group, asking them what they got out of their NAS group. And exercise was bottom of the list, if you like. They liked the fact they were with other people and that peer support, which is brilliant. I go to do the exercises, but it's facilitating all the other stuff that they get out of it.
Yeah, I'm just wondering if you might get as good a results if you just went to Pizza Hut for a chat and
yeah, quite possibly. They do a book club. I don't do the book club, but they do a book club. They've got the WhatsApp, but it's that commonality, isn't it, of people just coming together. And I try and get the exercise in at the back as well if we can.
Other pizza joints are available, I should say, shouldn't I? I was wondering, Heather, about, do you feel, it's difficult to say, I think I suspect at the moment, and I suspect data will come out into the future, but do you feel like there is a difference in being able to see the person face to face from a clinical point of view for both exercise interventions but also the assessments, that you lose, I suppose, do you lose a bit of that je ne sais quoi of just having seen people over a number of, I remember when I worked in rheumatology full time, and you just get used to that movement pattern that people have when they have loads of stiffness that Susie said. Do you feel like some of that is lost virtually and you need to keep that face to face?
I definitely do. I think it's being able to assess people, because people don't always know if they're feeling a bit stiffer. You obviously ask them, how do you feel? Yeah, haven't had a flare. Do you feel you're losing any mobility? And it's very difficult because people do sort of compensatory movements. They don't realise they're getting stiffer necessarily. And it's only when you see them and you can compare past measurements that you can actually have an objective view. And I think we went months, obviously, without seeing patients face to face. And it's only when I started seeing face to face again, I realised what I was missing. And I think particularly balance. And I when you haven't seen somebody balance and you give them balance exercises, you don't know where to pitch it. And if you haven't seen somebody move and you give them just random a splattering of range of movement exercises, you're not being so specific. And I think if you're going to give people, say, 3 exercises, you want them to be the really best 3 exercises that you can get, don't you? Because people don't want hundreds of things to do. They want to go off and do all their other activities. But if you want to really home in and say, these are the 3 I would do every day if you can, you want to get the right ones, I think. And that's where seeing them face to face is important. And like I say, I don't think you need to see them face to face all the time. Some patients you might do, but others, once you've got that idea, it might be perhaps a yearly or bi-yearly, whatever works.
Yeah, perfect. So I want to come on to you, Hannah, a little bit and talk about specific input versus more general input. We've obviously spoken to Heather a little bit there about sort of groups and bits and pieces like that. And I think when I read a lot of the research that's done for, let's say, just generalized physiotherapy for spondyloarthritis, there doesn't seem to be, from my reading of it, that one approach seems to be much better than another. So it seems to be like face-to-face individual treatment seems to be about as good as group treatment. Hydrotherapy seems to be about as good as walking programs, about as good as Tai Chi, which I know Susie's doing some training in and things. And there doesn't seem to be something that's like, this is the thing that's much better. But then as Heather's just alluded to, sometimes you can be better for individuals. So I just wondered if you would comment a little bit around that for us about sort of general versus specific input.
Yeah. I think it does depend on individual. We do always have to tailor everything to the individual. I think going back to the virtual versus the face-to-face, I think there is a bit of evidence that has recently come out where, patients do quite like, having the virtual aspect. There's a bit of evidence out there that we do well with the virtual, but we cannot assess as well. So I think that's important to consider when we're deciding whether we actually bring our patients in face to face or not, is that, we can miss things if we're only seeing people virtually. As Heather has said, patients don't always realise, what's changing. We actually have to assess the patient to be able to see that. So with regards to when we first see newly diagnosed patients, I think it's important that we do face to face so that we can get to grips with really what's going on with the patient, so that we can tailor to their specific needs. And also with patients we see have long-standing disease, when we're trying to work out whether they are experiencing inflammatory back versus mechanical back pain, the only way really we can determine which they're experiencing is to fully assess them. And I don't think you can do that successfully through virtual assessments. I've seen patients that I've seen during lockdown, and I'm convinced that they've got mechanical back pain, and then I'll bring them into the department, and then I realise that it's inflammatory in nature. And that's, despite me having clinical and worked with AS for many, many years, we are seeing people face to face when we need to. And I think there's specialist first, general physio, specific physios, what patients have access to. Some patients don't even have access to physiotherapy. let alone rheumatology physiotherapy. So I think it's about, first of all, trying to get all rheumatology patients and AxSpA patients access to physio, and then trying to upskill the physios that we have working in MSK. I mean, they have great background skills. It's just about adding that inflammatory element to the skill set.
I wanted to come to you, Susi, on just what Heather was saying about there aren't enough rheumatology physiotherapists to cover all of the departments and all the rheumatology patients. So we are going to need some of our MSK colleagues to help. Where would you suggest that they start? So if you're working in MSK, you've never seen an axial spondyloarthritis patient again, and suddenly you're going to be asked to be seeing them, where would you start with? What information would you be looking for, or what advice would you give those physios?
It really depends on two things: the present knowledge and the passion to learn from the physio. MSK physios, I mean, I am working in the MSK and rheumatology at the minute. It took me a long time to learn MSK stuff because everything is complex in rheumatology. MSK is a little bit easy. That's what my outlook is. So from an MSK physio trying to become a rheumatology, two things. If they are observed a rheumatology physio, then they know what is the dip in the knowledge they need to really fill in. If they haven't, they have to go along with evidence-based practice, which are scattered everywhere, from NICE guidelines to start off, and actually getting a rheumatology network group and asking. That's what I did. I can tell you my example. When I joined in, there was no rheumatology physio. I was the first rheumatology physio, and the previous physio left. So I had to get a network, and that's how I found AStretch, because I felt I wasn't having enough knowledge about rheumatology to go through, especially with ankylosing spondylitis. So that'll be, I will look at the evidence-based guidelines. I would learn to fill in the gap of my background knowledge, then go into networking with people to see what they can do, whether I can shadow people and get the knowledge from them. And the third one is also, I have to blow our trumpet. We have AStretch. It's a group of physios. We are always swimming in the evidence-based. Heather will agree on that. So I would say find a network group which has already been dealing with rheumatology on ankylosing spondylitis. So if it's possible, even lupus. So I would go into networking with those people to learn what I'm going to do. Say, for example, I'm only in MSK and I'm going to deal only with backs and differentiating between backs from the chronic inflammatory versus mechanical ones. I would look at a questionnaire to differentiate. That's quite easy to do. But I wouldn't know that unless I speak to somebody from AStretch or something. Same thing with lupus. I wouldn't know what to do, what instructions I would give, unless I closely observed or spoken to a consultant about it. So it is the knowledge where it is getting from an expert, where there is no randomized control trial to tell you, you go for an expert opinion. That's my way of looking at it. So you go for that. And again, if you learn to look at thirst, I would go even further to find out by trial and error, looking at the basic exercises, what I would do, and learning from my own experience and reflecting on it.
Lovely. I thought you were going for a play on words with swimming in the evidence base, because I'm right in saying AStretch do a hydrotherapy course today. I thought that was where you were going with that one. So Hannah, I was just asking Susi about the crossover skills from MSK into rheumatology and axial spondyloarthritis, particularly, and obviously you work across both fields. So what I was wanting to sort of get into was, if you're an MSK therapist and you're going to start seeing axial spondyloarthritis patients, what skills can you utilize immediately that you already have and build upon, and what newer skills do you think you would have to go out and seek?
I think a lot of it can still come back to the questioning. It's getting ingrained into, from student level to band 5 level and all the way up, into senior level, is trying to differentiate between the inflammatory and mechanical symptoms, and I don't think we do that enough. So I think it's still going. We still need to try and upskill people with the inflammatory screening, and that helps people to differentiate whether someone's experiencing inflammatory or mechanical pain. And I think that can be tricky for people when they're not seeing inflammatory patients all of the time. It doesn't mean that they don't have the skills to assess. I think they have the physical skills. I think it's the clinical history that needs a bit more work. But once they get the questioning in there and they're actually doing their assessment, the assessment really isn't a huge amount different when you come to assess a back. MSK Physios are very able to do that. That's what they do, all day, every day. I think there's a few tweaks that you can add in about making sure they're, palpating the SI joints, trying to focus a bit more on the thoracolumbar junction, these areas where we know that people get these inflammatory areas, to again just trying to help you differentiate whether someone's got active disease. And then when it comes to looking at their treatment, physios are very good at giving patients exercises that are tailored to their needs. So mobility exercises aren't really any different to anyone who has a back pain. Physios are very able to do that. I think again it's just adding in those few tweaks where it'll be about trying to target extension a bit more, the anti-gravity muscles, trying to focus a bit more on cardiovascular fitness, trying to focus on chest expansion. So it's just adding in those few extra bits, alongside the education as well, making sure patients have a good understanding of their condition, knowing that they do have an increase in cardiovascular risk. That's why you're adding in cardiovascular exercise, not just for the cardiovascular, not just about the thoracic expansion. If patients have an understanding why they're doing something, they'll do it for you. I know we're talking about patients getting good self-management skills and doing what the patient wants. But at the same time, we also have to educate them to know what their actual long-term needs are. And you can't get away from the fact that they need to maintain their mobility. They need to increase their extent strength. They need to improve their cardiovascular fitness. Again, looking at chest expansion, etc. So those things, we have to be putting that across to patients, to make sure that they can manage their condition long term.
Brilliant. Did you have any further comments on that, Susi?
Yeah. While you were asking a question about different ways, it's like a sea of answers. I think from the MSK level, people don't understand the fatigue levels with inflammatory conditions. They don't deal with it. Because I work with occupational therapists in the wards, I learned that from them, how to really assess fatigue, how to really put that as a limitation. The tolerance and compliance of the patient is very important with patients with axial spondyloarthritis, whereas with the mechanical back pain, you don't have to really, yes, you would consider, but not in that extent. And those 5 questions which you normally ask, we do an in-service training for all the MSK Physios. And that actually has nationwide we have done, even with AStretch, we have actually felt that 5 questions, how it can rule mechanical from the chemical inflammatory back pains, and how they can escalate that to a rheumatologist. That's very important because we are looking at delayed diagnosis, aren't we? We're trying to get from 8.5 to nearly 1 year. So we got to give that target. So if you're getting my MSK physios to address those patients, and if they're not going to be able to identify that, then we are going to be in a big loss. So a lot of training should be done in that so that we can capture those patients, get them the diagnosis done, and then treat them. So treating is another thing. Yes, you have to look at the compliance, tolerance. What else you can think? You need to know a little bit element of the blood test when the inflammatory markers are, higher up, when you can escalate on top of that. Even things like vitamin D levels and, all this hemoglobin, you need to have an eye on those. And how to interpret an MRI, how to read an X-ray is very important. Yes, people are very good in MRI, but then do they know how to detect spinal edema, sacroiliac edema? I learned going for a course with, I think we went, I don't know whether, Heather, you didn't come on. We went, 3 of the AStretch people, I think, went in London to learn. well, I didn't know how to really direct that. So those are the things, like, it's a holistic approach. And I don't think MSK physios will be able to do that unless we give them a package. And do we have a package? So we can't really give them no training and expect them to become rheumatology. That's my belief. But anybody can learn anything if they want to.
Yeah, we've got a good base, haven't we? We've got a good base.
Yeah.
Heather, I want to come. Oh, go on. Yeah, Heather's put her hand up for a comment. Yeah,
sorry, I was just going to add in. Obviously, Susi mentioned there's a lot of resource on the AStretch website, and there is loads of information. The NAS website has lots of, although it's related to patients, there's loads of information that I think would be really good if you're sort of an MSK physio coming into Axial SPA and you don't know a lot. There's so much information on the NAS website that on all aspects, whether it's fatigue, driving, uveitis, inflammatory bowels, there's all that connection. So yeah, that's a really good resource for not only patients but also therapists to look at.
Lovely. Hannah?
I agree there.
Just coming back to the identification of AxSpA, obviously we've got a big driver to try and reduce the delay to diagnosis. But I do think MSK physios are best placed to identify, and it's one of the big points I want to get across. It's not just about inflammatory back pain, is it? We get people coming in with their Achilles tendonitis, plantar fasciitis, tennis elbow, and they're the patients that people need to be asking about the back, asking the inflammatory screening questions. And I don't want people to be put off from referring if they're not sure. If people are only referring patients that get a diagnosis, they're not referring enough people. They'll be missing people. So say, I know our rheumatology departments are very busy, but we do need to be referring these patients, but particularly it comes back to the screening and asking the right questions.
Yeah, for sure. It sounds like either I've stolen that quote from you, Hannah, or you've stolen it from me, because that's exactly what I say on my courses when I deliver that information as well. And the other thing, just while we're talking about that, is if you're not referring as many women through with axial spondyloarthritis as you are as men, then you're missing them, because we should be getting the same numbers, shouldn't we? Heather, I want you to come to you to talk about sort of pragmatics, really. I was speaking to a department not so long ago, and they were saying they've got a certain number of sessions with each patient because they've got this waiting list, COVID related, staffing related, all these bits and bobs, but they're limited with the number of sessions. So if people are limited, what's the biggest bang for a buck, or what would you, let's say they were limited to 2 or 3 sessions or something, what would you say, what is the must covers, and then what's sort of the nice to cover after that?
I guess the must covers is, as Susi said originally, what is the patient wanting to get out of physio? What do they come with? What's their agenda? Because if you go off on your own agenda and you don't get to the patients, you're not achieving a lot. So it has to be patient-led. I guess if it's physio and patient-led together, where you're sort of nurturing them, it's just looking at their general fitness, their general activity. But also, as Susi said, fatigue is such a problem. You can give people lots of exercises, but if they're very fatigued, they're probably not going to do them. So I guess it's the education about what the condition is. And I think education is so important, what they want to get out of it, what actually axial SPA is to them, what it limits them doing, what they want to achieve. So that I think education is so important. So yeah, very much patient-led. I think if you are struggling with sessions, then it is looking at whether or not group sessions are going to be useful. So that perhaps initial one-to-one to actually see where the patient's at, are they at a point where they want to go into a group session, and then trying to get patients into a group. And that's often more cost-effective because you can get, 20 people on a Zoom call as opposed to one, and exercise on a Zoom call. So I think there's ways around it.
Yeah. Okay, brilliant. Just my sort of final little bit, really. And I'll come to you, Hannah, first for this, but then I would like Susi and Heather as well, if you can comment. It's a question I get on my courses all of the time is about what changes we would make, if any, to interventions once patients have got fusion. So everybody seems to be very concerned about, once their patient has some spinal fusion, about what they should be doing. So I wanted to really get some information about that, really. Should we make great big changes? Is there anything specific we should do or should avoid?
If we know patients got fusion, then they've got increased risk of fracture if you were to do your manual therapy. So that's one to be aware of. Making sure that you're not doing your heavy manual therapy on them. We also need to be cautious anyway because of the increased osteoporotic risk. So we should be more aware, not just with women but with men as well. With the manual therapy. That's not to say that we can't do manual therapy. Of course we can, but you've got to judge the level of disease activity, progression, and the age of the patient.
The major ones Hannah's just mentioned about the osteoporosis, I would look at the balance because the balance is going to be disturbed. So I would look at risk assessment, slips and falls. I would look at the footwear, what sort of adaptations they need to do, environmental checks, workplace assessment if that person is working or they're doing any different hobbies. I would look at cardiovascular input, whether they could still do the breathing exercises, avoid further fusion of the shoulder and hips. So further prevention can be prevented by giving them adapted resting positions, because I've had 3 patients like that. And one GP, I have to tell you a small story. A GP told a patient to go and use a waterbed, and she used it. And within 2 years, she got completely fused. That was the first patient I saw with ankylosing spondylitis. That was 5 years ago. So use of good beds, mattresses, especially adapted to that. I've given wedge cushions to keep the hips in abducted position. Things like that, problem-solving approaches, which the person need to self-manage, because not necessarily we need to leave them because they are fused, but we got to prevent still. Prevention is still there, and maintenance should be done. So that is, I can't tell in words. It depends on the individual and what actually lifestyle they lead. If that makes sense.
Mm-hmm. Yeah, absolutely. Anything else, Heather, on there that you think we would add in or change?
I think we've added quite a lot, to be fair. The only thing I was think of, if somebody's pretty fused, is driving, and being mindful of mirrors. Obviously you can get adapted mirrors, and also the head support. So if somebody was hit from behind, you need to make sure that they have a head support, that if they are sort of in a fixed flexion position. So yeah, I guess that's the only thing that might be extra that you could add in.
Brilliant.
And then the swallowing, obviously it comes up straight away, isn't it, if the person is quite tachyphotic. And yes, we have had problems with bringing the salt people in to give some, yes, it has gone to that extent.
Yeah. And Heather, just to finish on the osteoporosis front, you'll see this in your clinics. I'm right in saying that when someone has fusion, it messes with the DEXA scanning, doesn't it? Have you got any advice for us around what to do about that?
Yeah, it's difficult because you get obviously more bone growth and less bone growth in the vertebrae, which makes it hard. Obviously, you can do a hip DEXA, but it is more the spine that's going to be affected by the osteoporosis. So I guess it's taking the patient in as a whole. Obviously, that the osteoporosis is worse early on in treating the disease. They lose sort of more bone earlier on, and certainly if the disease is controlled, so if it's somebody that goes straight onto biologics, they're less likely to get osteoporotic. But it's bearing in mind obviously the age of the patient as well. Certainly gender makes a big difference, but you can't trust a DEXA scan if somebody's got fusions of their spine, because it just doesn't give you a clear reading.
Yeah, brilliant. Yeah. Okay, great. Well, thank you very much to the three of you for spending the best part of an hour with me chatting over these things. I just wanted to give you a last opportunity. Anything that you wanted, I can guess at least one thing that we might be promoting a little bit of, but any signposting you wanted to give the listeners to further information or further projects that you guys are involved with. I'll start with you, Heather.
So yeah, have a look on the AStretch website. In December, we did 12 days of blogs. So there's a new blog each 12 days. And once a month, there's a new blog that goes out, which looks at different aspects of AS, whether it's research, whether it's exercise. But that's a really good, excuse me, and it's updated constantly. So that's a really good resource.
Brilliant. For you, Susi?
I would second. I'm a Facebook admin for AStretch. So yes, please look at and like it and comment it. And also look at NAS, because I haven't really promoted NAS with all my works. But NAS has got absolutely, I tell all my patients to go and look at it first. So NAS and AStretch are the most to be promoted. And keep moving. Yeah, keep moving.
Brilliant. And finally to you, Hannah.
And I agree, really, the NAS website is a great resource, not just for patients, but also clinicians. There's the back to action within the NAS website, which is a great resource for exercises. So if people are new to rheumatology or new to treating AS, it's a great place for people to go to get ideas about what exercises to advise patients.
Brilliant. Thank you very much. Well, once again, thank you very much for... go on. Sorry, Susie.
I'm sorry. I love dancing. My husband is a choreographer. So Bollywood dancing, we promoted with it. So keep innovating ideas with people with Axial SPA, because they get bored. So anything new. So I promote dancing. So it is good. And music and relaxation helps. That's why I chose Tai Chi and dancing. So anything innovation, keep it coming.
Brilliant. And we'll see you on the tech innovations, Susie, won't we, soon? You'll be designing an app or something. Brilliant. Thank you very much to the three of you. And I hope that everybody's enjoyed that chat. I found it very interesting and lots to learn. And I think we can all improve, especially anybody who is working in musculoskeletal practice and is being asked to see axial spondyloarthritis patients, or even is interested moving into rheumatology. And lots of departments need more rheumatology physios. So certainly a good way to go. And everybody needs to go check out AStretch and NAS, and I'll put the links in to the show notes of the podcast as well. So thank you to the three of you, and hope you have a good rest of the evening.
Thank you.
Thank you.